Hello and welcome to this review session on ocular anatomy. If you can hear me okay, can you give me a thumbs up? Great. Let's just give a couple of minutes to see if any more people would join this meeting, and then we'll probably start in a couple of minutes. Okay, I guess that's pretty much it. So in this review session, I'll be going through some of the important anatomical landmarks of most of the ocular tissues actually. And this session will also include a few points on vascular and nervous system. As you can appreciate, ocular anatomy is a very vast topic to cover in a single lecture, but what I thought I would do is to highlight some very important points for you to take home, which might be useful for your board examinations. Throughout this session, I'll also be doing some polls. These are anonymous polls, so I encourage you to participate as much as you can. Also, if you have any questions, please drop them into the chat box, and I'll monitor the chat box from time to time for your questions. Okay, let's start with the skull and orbit. And here's a quick poll question for you to begin with. What is the total number of facial bones, A10, B12, C16, and D14? You can respond to this poll by clicking on the link in the chat box. There is a link in the chat box. If you click on it, you should be able to see these options and you can pick one of those. Okay, looks like we did not get any response, but the correct answer is 14. As you know, the skull is made up of 22 bones, which includes 8 cranial bones and 14 facial bones. Let's look at these bones in a little bit more details. You can remember the cranial bones by the mnemonic 8 osseous parts from the skull. And these bones are frontal, parietal, parietal here, temporal, occipital at the back, and then your ethmoid and your sphenoid just inside the frontal part of the face. The important point to remember here is that parietal and temporal, since these bones are on the two sides of the skull, these are paired bones, and rest of the other bones are single bones. So 2 paired bones, 4 single bones, total number of bones, 8. Now, if you look at some of the prominent structures in these bones, the ethmoid bone has an ethmoid sinus. And if you remember, there are 4 sinuses, frontal, maxillary, ethmoid, and sphenoid. The ethmoid bone also has cribriform plate through which the olfactory nerve passes in this structure. It also has cristae galli, which is a cell-like projection, and the membrane from the brain attaches around at this portion, so that the brain cannot move freely in the skull. The occipital bone, which is at the back, has a lambdoidal suture, so called because it is in the shape of the Greek letter lambda. It also has a foramen magnum through which the brainstem passes and connects to the spinal cord. It has external occipital protuberance which you can feel at the back of your head, and occipital condyles right at the bottom here, which attaches to the cervical vertebrae, first cervical vertebrae actually. And the parietal bone, if you look at the parietal bone, it has coronary suture in the front, squamous on the side, and lambdoidal at the back. And the parietal bone is separated into two halves, right and left, by the sagittal suture. Now, the frontal bone has a foramen for the passage of supraorbital nerves. This is called supraorbital foramen. The temporal bone has squamous suture that separates it from the parietal bone. It has a zygomatic process here, and also auditory meatus, which is a small hole that connects to the ear. It has mastoid process at the bottom here, and a stelloid process. Mastoid connects to the neck muscles. Stelloid process connects to the tongue and the larynx. And there is a portion called a terion, which is the weakest part of the skull. This is where the frontal, parietal, and temporal, as well as the sphenoid bone, connect. And so this is the weakest point in the skull. If you look at the sphenoid bone, this is butterfly sept, as you can see here. It is the only bone that connects to all other bones, has a greater wing and a lesser wing. It has a pterygoid process, and it is near sella turcica. It has a sella turcica, which houses the pituitary gland just 10 millimeters below the optic chiasm. Now, coming to the facial bones, you can remember these by the mnemonic: my mandible chews 9 very large zucchini pieces. And important point to remember here is the pair bones, maxilla, and then there you have your inferior nasal concave. There's a nasal bone on either side of the nose bridge, and there is a lacrimal bone just near the nose bridge as well. So these are paired. There's also zygomatic bone, which is paired, and palatine bone, which is just inside of this the frontal part of the skull, that is paired. The only single bones are vomer, right here, and then the mandible, which is a single bone at the bottom of the face. Now, some important structures in these bones: the maxilla has infraorbital foramen for the passage of infraorbital nerves. It also has incisive foramen. It is located on the hard palate, just at the roof of the mouth. And this is for the passage of sphenopalatine artery and nasopalatine nerves. The mandible has a mental foramen. This is for the passage of inferior alveolar nerve, which is a branch of mandibular nerve of the trigeminal nerve. It also has coronary and coronoid and condylar processes. And there is your mandibular foramen, which is just in the inside, that where the alveolar nerve opens up. The lacrimal bone is actually the smallest bone in the skull. It helps form the lacrimal canal. The zygomatic bone is the cheekbone, as you know, and a palatine bone helps, which is just inside, helps form 3 cavities: orbital floor, lateral floor, and the roof of the oral cavity. And the other important structures, of course, is the cranial fossa, which houses many different structures. And so it is important to remember the 3 different fossas: anterior, middle, and posterior fossas. When we talk about vascular structures, vasculature, we often mention these cranial fossas. And so now that we have learned about the facial bones, it is important. It is easier to remember the orbital bones. Cranial facial bones basically make up these orbital bones. The single bones are frontal, ethmoid, and sphenoid, and then the paired bones are maxillary, zygomatic, lacrimal, and palatine. If you want to remember by the mnemonic, here is a mnemonic for you. But this is if you keep a picture in mind, then that becomes easier. We'll come to the picture in the next slide. But before that, here's a poll question for you. Which bone has the smallest contribution to the orbital structure? A, ethmoid, B, frontal, C, palatine, and D, lacrimal. You can click the link on the chat box and respond to this poll question. There should be a link in the chat box. You'll see an option to respond, and you can pick one of these options. Okay, the correct answer is palatine bone. I'm sure many of you got it correct. Now let's look at the frontal view of the orbit. The volume of the orbit is around 30 milliliters, which is 5 times the volume of the globe. And some of the prominent structures here, here's your supraorbital foramen, the supraorbital margin here, your nasal, lacrimal, and ethmoid bone on the medial side, infraorbital foramen on the floor, in the maxillary bone, and here's your zygomatic bone. Now let's look at the margins of the orbit. The supraorbital margin is basically formed by the frontal bone. The infraorbital margin has 2 bones, a zygomatic bone on the lateral side, a maxillary bone on the medial side. The lateral margin consists of the frontal process of zygomatic bone. So the process is actually part of the bone that connects to the other bone. So this part of the zygomatic bone connects to the frontal bone. So this is called frontal process of zygomatic bone. And this part is called zygomatic process of frontal bone. So the lateral margin is formed by these 2 parts. The medial margin is formed by the maxillary process of frontal, the part of the frontal bone that connects to the maxillary bone. And then there's your lacrimal crest just inside here. So if you keep this picture in your mind, then you can probably outline the margins pretty easily. Now let's look at the orbital walls, and I've included some mnemonics for you to remember. But really, what you need to do is just try to picture this in your mind. If you look at the roof, you have your orbital part of the frontal bone. Frontal bone just as it goes into the orbit, so this is called the orbital part of the frontal bone. You have your laser wing of the sphenoid here. So the laser wing of the sphenoid, orbital part of the frontal bone, is the roof. The floor basically is made up of orbital part of the maxilla. You have your palatine just inside, zygomatic bone. So the 3 bones make up the floor. The medial wall, you have your body of sphenoid here, just inside, and then frontal process of maxilla. Here's your ethmoid bone here, and then your lacrimal bone. And the lateral wall is just 2 bones here, this greater wing of sphenoid and the zygomatic bone. So if you try to keep this picture in mind, you can probably outline all the major landmarks of the orbital wall. So what happens in blowout fracture? If there's a trauma with a physical force to the orbit, then what happens is that the inferior wall is broken, and most of the contents drop down into the maxillary sinus. So you see the contusion in that part, and of course the inferior rectus is here, so it is entrapped. It causes diplopia, and if you try to move the globe with the forceps towards this muscle, then there's a resistance. Oftentimes the globe is sucked into the orbit, and also you lose sensation on this part of the cheek, just inferior. You may also see some grating sound produced by the friction between bone and cartilage in this condition. Well, why the middle wall is not broken? This is because it gets some sort of support from the ethmoid bone just inside of the medial wall. Now, some of the important points to remember here is that the lacrimal groove is in the medial wall, and this is where the lacrimal sac is located. Lacrimal fossa is in the superior wall, actually superior temporal wall, where the lacrimal gland is located. The roof separates orbital cavity from the anterior cranial fossa, and the lateral wall of the orbit is the thickest wall, but the thinnest is the medial wall. But remember that in blowout fractures, the wall that is often broken is the inferior wall. The medial wall has some support from the ethmoid just inside. The orbital floor is the commonest site of fracture, as we discussed. And when there is breakage of bones in the orbital margin, it is called the comminution fracture. Mostly occurs in frontal, zygomatic, and maxillary, because these are the bones that form the margins of the orbit. And one of the most common cause of orbital cellulitis is the sinus infection. And the most common route is through ethmoidal sinus in the skull. Now let's look at some of the fissures, fossa, and canals, because these are the important landmarks associated with several different nerves and arteries in the eye. You have your optical canal here. It is, as you can see, it is located in the lesser wing. The greater wing is on this side, and then these fissures, superior orbital fissure and inferior orbital fissures, separate the sphenoid bone into greater and lesser wings. So the optic canal passes the ophthalmic artery and also the optic nerve. Now, when you look at the orbital fissures, the superior orbital fissures, there are several nerves that are passing through these orbital fissures. And some of the important nerves are lacrimal, frontal, and trochlear. Now, this ring here, this is the origin of the extraocular muscles, and this is also called the common tendinous ring. And one of the most common questions is the structures that pass through these fissures above, below, or through those rings. So let's look at those structures in a little bit more detail. But before that, here's a poll question for you. Ophthalmic artery and vein pass through the optic canal. Is this true or false? Again, you can respond to this poll question by clicking on the link in the chat box. This is anonymous poll, so I encourage you to respond to the polls. Ophthalmic artery and vein pass through the optic canal. Is it true or false? And the correct answer is it is false. And we'll come to that in a bit, but let's look at the structures that pass through these orbital fissures. Just above the common tendinous ring, you have your lacrimal, frontal, trochlear, and superior branch of ophthalmic vein. You can remember this by the mnemonic SOV for LF. Through the common tendinous ring, you have NOA, nasociliary nerve, abducens nerve, and oculomotor nerve. And just below the common tendinous ring, you have your inferior branch of ophthalmic vein, inferior ophthalmic vein, just through the common tendinous ring. And through the optical canal, it is ophthalmic artery and optic nerve. So ophthalmic artery passes through optic canal, but the ophthalmic vein actually passes through the fissures, superior and inferior orbital fissures. Now, when you look at the skull in neonates, these are slightly different from adult skulls in that these are disproportionately large relative to the face. And with age, the sinuses start to develop. So that increases the face length. There are these fontanelles in the skull of neonates, just at the junction of parietal and frontal, and then parietal and occipital, which are called the anterior and posterior fontanelles. The mastoid process of temporal bone is usually not formed in neonates. And then the facial bone, facial nerve is very close to the surface, so it can be easily damaged during the forceps delivery. Coming to the eyelids next, let's look at some of the attributes of eyelids and measurements. You have your marginal reflex distance, which is 1 and 2. 1 just above the pupillary reflex here. The MRD1 distance is 4 to 5 millimeters. The MRD2 is around 5 to 6. So the total palpebral fissure height is around 9 to 11 millimeters. Upper eyelid, as you can see in the picture, is slightly below the upper limbus, and the lower eyelid is again slightly below the lower limbus. The upper lid has more lashes than the lower lid. And when removed, these lashes take around 4 to 6 weeks to grow again. What are the layers of the eyelid? Well, when you go from outside of the eyelid to inside, you can remember that by the mnemonic SOS, more TPC. The outermost layer is the skin here, which has the sweat and sebaceous glands, such as these and mole. Next is the orbicularis oculi muscle. You have your palpebral portion here. The orbital portion is slightly up here. And then you have your septum, that is the anterior boundary of the orbit. The muscular part contains the levator muscle, and you have also your muscle of Muller muscle and Horner muscle. The tarsal part contains meibomian glands, which are arranged parallel in the upper and lower eyelids. It also has glands of Wolfram, which is the accessory lacrimal gland. And the innermost part is the conjunctiva here, just inside. Another poll question for you here: which muscle closes the palpebral fissure? A, levator superioris, B, orbicularis oculi, C, inferior rectus, and D, Muller's muscle. You can respond to this poll again by clicking the link in the chat box. You have 5 more seconds, and then we'll get to the answer. So the correct answer is orbicularis oculi, which closes the eye. It actually has 2 parts: orbital part, which is responsible for the forceful closure, and the palpebral part, which is the spontaneous or reflex closure. The orbicularis oculi is innervated by the 7th cranial nerve, facial nerve. The muscle of Horner is located on the medial side. It encircles the canaliculi and helps drain tears into lacrimal sac. The muscle of Rheolon is at the tip of the lid, actually at the lid margin, helps in tear drainage again, and keeps the lid opposed to the globe. The levator muscle helps to open the upper eyelid. It is a striated muscle innervated by the oculomotor nerve. And the Muller muscle helps support the function of levator muscle by maintaining the elevation of the upper eyelid. It has sympathetic innervation. We'll go into that in the upcoming slides. Let's look at some graphical illustrations here. Here is your orbicularis oculi muscle, the outermost orbital part, and then the closer to the lid margin is the palpebral part. The Rheolon muscle here is located on the lid margin here, which helps to keep the lid opposed to the globe. Your orbital septum is the anteriormost boundary of the orbit, and it separates the eye globe from the orbital fads. Here's your muscle here. Levator muscle comes from the apex of the orbit, and as it comes through, the Muller muscle also projects from this muscle. And your nerve supply comes from the 7th cranial nerve to the orbicularis oculi muscle here. And if you look at the muscle arrangement on the superior part of the globe, you have your levator muscle first, and then you have your superior rectus, and just underneath your superior oblique muscle here. And these horner muscles, they line the canaliculi at the medial side and helps to drain the tears. Now, some of the differences between reflex blink and spontaneous blink, which might be important for examinations. The reflex blink is caused by sensory stimuli. It is often very fast, 150 to 200 milliseconds. And during this blink, the upper lid closes palpebral fissure completely, as opposed to the spontaneous blink, where the upper lid does not close the fissure completely. Spontaneous blink occurs every few seconds. And in this blink, the upper lid moves slower, 250 to 300 milliseconds. This blink helps move tears across the cornea. So the vertical lid movement causes the tears to move vertically, and then the horizontal lid movement causes the tears to move medially and towards the lacrimal canal in the medial side. Here's a chat question. Here's a question in the chat box. Are both blinks done by cranial nerve 7? Well, your spontaneous blink and reflex blink, remember the closure of the eyelid is from the muscle, Muller muscle. So these are innervated by cranial nerve 7. So these blinks are normally governed by cranial nerve 7. When you look at your glands in the eyelids, you have your meibomian glands, which are sebaceous holocrine glands. These are in the tarsal plate here. These are arranged in parallel in the upper and lower eyelid, more in the upper eyelid than lower eyelid. And inflammation of these glands can often lead to a condition called chalazion. You have your Z's gland, just at the follicle, base of the follicle, eyelash follicle. These are modified sebaceous glands. And the infection of these glands can lead to something called stye. You have your glands of mole just nearby the G's. These are modified apocrine gland. And you have your accessory lacrimal glands, which are Wolfring and Krauss. Wolfring in the tarsal plate and Krauss just in the fornix. These help to produce aqueous tears. They make small contribution to the aqueous tears. Most of the aqueous tears is produced by the lacrimal gland itself. So what do you mean by the holocrine, apocrine, and merocrine glands? Well, holocrine glands actually secrete whole cell as part of the secretion. So an example of this is meibomian glands. The apocrine gland, for example, mole or goblet cells in the conjunctiva, they secrete the part of the cell as the secretion, whereas the merocrine gland just produce secretion, but oftentimes no cell involvement is there in the secretory product. For example, the main lacrimal gland, which produces the aqueous tears. And you have some other muscles that are innervated in the around the eyebrow muscles. You have your frontalis, which helps to elevate the eyebrows. When you're concentrated, you've got your corrugator muscle supply from cranial nerve 7. Orbicularis oculi, as we talked about, it helps to close the upper eyelid. And when you're angry, the procerus muscle is in action, again supplied by the cranial nerve 7. Now let's look at the conjunctiva next. And the conjunctiva can be divided into two different parts, the bulbar and palpebral conjunctiva. And palpebral conjunctiva is packed with defense. So you can remember with just the initial of these words. The conjunctiva contains mainly 2 layers, non-keratinized epithelium. The palpebral one contains 2 layers. And then there's the deeper layer is stroma. The epithelium contains goblet cells, which produces mucin. And these help to lubricate the corneal epithelium and also help with the attachment of tears. The stromal layer of the conjunctiva has defense mechanism in terms of immune cells, immunoglobulin A, mast cells, and also has a deep fibrous layer where the accessory lacrimal glands of Crouch and Wolfring are located. Let's look at the innervation to the eyelids next. Now, if you remember the ophthalmic branch, which is the V1, this is the first branch of the trigeminal nerve, divides into three different branches. You can remember this by the mnemonic NFL, nasociliary, frontal, and lacrimal. And nasociliary itself divides into four different branches: your long ciliary nerve, short ciliary, infraorbital, and then your ethmoidal nerve. So, oops. So you can remember the innervation to the eyelids by these mnemonics, and the ones highlighted in red are the ones supplying the eyelids. So infraorbital, supratrochlear, supraorbital, and lacrimal, which are the branches of the ophthalmic nerve. When you look from the frontal side, you can remember by the mnemonic. We have a couple of more people joining in, so let's admit them. You can remember by the mnemonic LOT on the superior side and ZOT on the inferior side, lacrimal, supraorbital, and supratrochlear. On the lower side, zygomaticofacial, which remember is a branch of maxillary, V2, and infraorbital and infratrochlear nerve. These are the branches of the V2 maxillary, the zygomaticofacial. Now, when it comes to blood supply to the eyelid, it is from both external and internal carotid arteries. The external carotid artery blood supply is mainly by the facial artery. The internal carotid artery blood supply is from ophthalmic artery, which gives rise to medial palpebral and lateral palpebral arteries on the lateral side. And these anastomosize to form an arcade just in front of the globe. You also have your anterior ciliary arteries, which come from muscular artery branch of ophthalmic artery, and this supplies the bulbar conjunctiva. The palpebral conjunctiva is mainly supplied by the medial and lateral arteries, palpebral arteries. One thing to note is that the lateral palpebral artery is a branch of lacrimal artery. It's not the direct branch of ophthalmic artery as it is on the medial side. The lymphatics, the one from the lateral side drain into the parotid, and the medial side drains into the submandibular. You can often find swollen lymph node in conditions like EKC, dermal keratoconjunctivitis, where the lymph nodes are swollen, and oftentimes you see corneal infiltrates because of the virus infection. Now let's look at the lacrimal system in a little bit more detail. This flowchart here just outlines the direction of the flow of tears from the point of production to basically the point of exit. So here's your lacrimal gland, and then it drains into the lacrimal ducts, which drains the tears onto the ocular surface. From there, on the nasal side, you have your lacrimal puncta, lacrimal canaliculi, your sac. There's a nasal lacrimal duct, and then it goes into the inferior nasal meatus. And then to the nasopharynx. Well, finally, it is mixed with mucus and it is swallowed. But you have your valve of Hessner here, right at the bottom of the nasolacrimal duct, which helps to prevent the tears from going back into the nasolacrimal duct itself. Now if you look at the measurements, you can remember by this 8, 10, 12 ordering of numbers: canaliculi, sac, and nasolacrimal duct. And usually the tears drain by pressure and suction, and mostly the tears are draining through the lower punctum. Almost 70 to 80% of the tears are drained through the lower punctum. When we look at the lacrimal gland, it is an almond-shaped gland located in the superior temporal part of the frontal bone in the orbital fossa. It is exocrine. It releases contents by ducts, and it has two parts: orbital part, which is the bigger one. The palpebral part is next, which is closer to the eyelid. And it also gets support from the accessory glands of Krause and Wolfring. About 10% of secretions come from those two accessory glands. Now, blood supply to the lacrimal gland, as you can see on the lateral side, it is on the lateral side, so it is through lacrimal artery. The lymphatics, it is on the lateral side again, so it drains into the parotid. The innervation to the lacrimal gland, it is mostly motor, but also receives the sensory innervation and sympathetic innervation. The sensory one, if you remember again, the branch of ophthalmic nerve, which you can remember by NFL, nasociliary, frontal, and lacrimal. So that's the one that supplies the lacrimal gland. The sensory supply comes from lacrimal nerve. The involuntary motor is from the parasympathetic, the lacrimal branch of the facial nerve. The sympathetic comes from the superior cervical ganglion, which provides the sympathetic fibers to the lacrimal gland. But mostly it is motor. Now let's look at the extraocular muscles. Here's again your poll question: which muscle originates from the front of the orbit? You can respond to this poll by clicking the link on the chat box. This is an anonymous poll, so please do participate if you can. A, superior rectus; B, inferior oblique; C, inferior rectus; and D, superior oblique. Which muscle originates from the front of the orbit? Okay, and the correct answer is inferior oblique, which is the one that originates from the front of the orbit, as you can see here. All of the muscles, all of these 6 muscles, these are, sorry, four of these 6 muscles, these arise from the apex of the orbit, which is called the annulus of Ginn, and they attach in front of the equator, these rectus muscles. But the oblique muscles, the superior oblique, although it originates from the annulus of Ginn, it has a trochlea here. So the physiological action of this muscle, basically the origin is from the trochlea, and it attaches behind the equator. And if you look at the inferior oblique, it comes from the maxillary bone, front of the orbit, and it again goes behind the equator where it attaches to the globe. Here's your inferior oblique, arises from the orbital surface of the maxilla in the floor of the orbit, and goes back, attaches just behind the orbit. Here's your superior oblique muscle. It arises from the undersurface of the lesser wing of sphenoid, goes medial, and then turns around through the trochlea, attaches just behind the orbit here. A few points to remember about extraocular muscles, which could be helpful for you. In terms of, in order for this to closest to the limbus, the muscles are superior rectus, lateral rectus, inferior rectus, and medial rectus. So superior rectus is the furthest away from the limbus. The innervation to the muscles can be remembered from the mnemonic LR6SO4O3. Lateral rectus supplies the lateral rectus is supplied by the 6th cranial nerve abducens. Superior oblique is from the fourth, trochlear, and others are from the ocular nerve. It also has two branches, superior and inferior. Superior branch supplies superior rectus and your levator, and the inferior branch supplies inferior rectus, inferior oblique, and medial rectus. One point to remember is that the trochlear nerve of one side actually supplies the superior oblique of the contralateral side, because decussation of fibers occurs in the midbrain. And your blood supply to the muscles come from medial muscular artery, which supplies the medial rectus, inferior and inferior oblique. And the lateral muscular artery supplies the superior rectus, superior oblique, and your levator muscle, also the lateral rectus muscle. Here are some mnemonics that you might find useful to remember this blood supply. Another point to remember is that each rectus muscle receives two anterior ciliary arteries, except the lateral rectus, which only receives one anterior ciliary arteries. And these are the branches of the muscular arteries. Now let's talk about the actions of these muscles. And here's the table with primary, secondary, and tertiary actions. The action of medial rectus and lateral rectus are self-intuitive. Some of the mnemonics that can help you remember these actions are recti ad, so superior rectus and inferior rectus. Basically, their tertiary action is adduction. Obliques abs out, so the tertiary action of these obliques are abduction. Inferior extort, the inferior rectus and inferior oblique, their action is extorsion. Superior do not extort. Superior rectus and superior oblique, their action is intorsion. And the action of superior oblique is in-depth abs, so intorsion, depression, and abduction. The actions of inferior oblique are extorsion, elevation, and abduction, excellent abs. And when it comes to the vertical movement, obliques actually act opposite. So superior oblique is depression and inferior oblique elevation. Now here's the cardinal positions of gaze, which helps you to remember which muscles are involved when you move the eye to a certain, excuse me, certain cardinal position of gaze. For example, if the eye is up here, looking at superior temporal side, then the muscles that are involved are superior rectus from the right eye and inferior oblique from the left eye. So if you remember this, it helps you to remember which muscles are in action when the eye is moved to a certain direction from the primary position of gaze. Now let's look at the cornea next. The cornea has 5 layers from outside to inside. It is epithelium, Bowman's layer, stroma, decimates, membrane, and the innermost layer is endothelium. The 2 layers that can regenerate, epithelium, of course, but in some capacity, decimates can also regenerate. So epithelium and decimates membrane. The epithelium normally contains type 1 collagen, whereas the endothelium is rich in type 4 collagen. And the thickest part is the stroma, of course, which is around 450 microns, 80 to 90% of the whole corneal thickness. Some of the dimensions of the cornea to remember are that the diameter is greater horizontally than vertically. The limbus is widest in the superior and inferior cornea. And the radius of curvature of the anterior surface of the cornea is greater than the posterior surface of the cornea. The cornea normally contributes around 70% of total refraction, so 40 to 44 diopters of refractive power. And this is because when you see the interface of the cornea and tears and ear, have your differences in refractive index. And because the power is a function of refractive index, Basically, this difference in refractive index contributes to such a large power for the cornea. It is thicker in the periphery than center, and the cornea contains both cellular and acellular components. The acellular components mostly being glycosaminoglycans and collagens. Type 1 is the most common collagen found in cornea, also to some extent in sclera. And an important distinction to sclera is that the collagen fibers in cornea are uniform and they are organized, and this contributes to maintaining transparency in the cornea, unlike sclera where the fibrils are random. So the sclera is mostly opaque. Now, there are several junctions in the epithelial layers of the cornea, and these are zonula occludens, macular adherens, and hemidesmosomes. Now, we can divide the epithelial cells into superficial wing and basal cells, and the zonula occludens is mostly in the superficial cells. Macular adherens, basal to basal connection, wing to basal connection, and wing to wing connection. And the hemidesmosomes is at the lowermost side, basal, at the basal lamina. There's your macular occludens, which is in the endothelium of the cornea. So these are some of the important junctions to remember when it comes to corneal connection, different connections between different cells in the cornea. Now, of course, the corneal epithelium can regenerate, and the way this occurs is by the movement of stem cells from into the basal cells, and basal cells to wing cells, and these are often connected by zonula occludens. Now, the palisades evoked are these radially oriented vascular regions that you can see just next to the limbus area, and the stem cells from that area migrate to the basal cells, which through mitosis, and then they connect to the wing cells. This whole process can take somewhere around 7 to 10 days to complete. Now let's look at some of the important conditions in the cornea, classified by layers of the cornea. In the epithelium, you have your epithelial basement membrane dystrophy, which is the most common anterior dystrophy. This is often a result of a faulty basement membrane due to the lack of hemidesmosomes. And this causes a poor connection between the epithelium. And often you can see the map or fingerprint pattern here. In Bowman's layer, you have your crocodile segrine, which are the polygonal mosaic grayish white opacities. It can be both anterior and posterior. Anterior in the Bowman's, but posterior is in the stroma and endothelium as well. You have your limbal girdle of both, which are white flecks just at the nasal and temporal cornea. And don't confuse this with arcus senalis, because arcus senalis often tend to be circumferential around the cornea, or superior inferior mostly. In the stroma, you have the most common bilateral stromal dystrophy is the lattice stromal dystrophy, which occurs in childhood. This can accompany the corneal erosions, but these erosions often occur before the stroma is involved, and oftentimes you'll see a reduction in vision resulting from this dystrophy. And in Descemet's membrane, you have your Hasselhenle bodies, also called guttate. And this is because of the increased thickness of the Descemet's membrane. It can be peripheral. Don't confuse it with Fuchs dystrophy, which is oftentimes central and occurs in females aged 40 to 60 years. So these are some of the important corneal dystrophies to remember in different layers. When it comes to blood supply in the nerve supply and blood supply in the cornea, the nerve supply, again, remember the NFL acronym, branches of the ophthalmic nerve. nasociliary, frontal, and lacrimal. And nasociliary gives rise to LIES, L-I-E-S, long ciliary, infraorbital, ethmoidal, and short ciliary. Basically, long ciliary and short ciliary are the main nerve supply to the cornea, and these enter the cornea mid-stroma, but they lose their myelin almost 1 millimeter after entering the limbus area. There are several nerve endings in the cornea, so it is highly sensitive, and these endings arise from a lot of other nerves, from medial and lateral long ciliary nerves. In terms of blood supply, the main blood supply is from the anterociliary arteries, which are branches of the ophthalmic arteries, sorry, muscular branch of the ophthalmic arteries. And you have your long ciliary artery here that comes from the ophthalmic artery as well. Let's look at conjunctiva in a little bit more detail than before. When you see the layers of the conjunctiva, the epithelium is stratified and non-keratinized. Stratified because it has several layers. The stroma contains 2 layers, and again, the stroma is filled with the immune cells, helps to protect against infections. And there's your deep fibrous layer just underneath the outer lymphoid layer. And the conjunctiva can be separated into several different components based on their location. So marginal, tarsal, orbital, pharyngeal, and you have your bulbar just in the white part of the eye. And the connection between cornea and conjunctiva, of course, is the limbus here, cornea and sclera as well. The limbus is the junction. And when you look from the frontal side, you have your bulbar conjunctiva. Pharyngeal is just at the fornix. Tarsal and marginal, these are the part of the palpebral conjunctiva, which are near the lid margin. Let's look at the limbus a little bit more. The anterior border of the limbus is at the termination of the Bowman's and Decimet's membrane. And the posterior border is around 1.5 millimeters from the anterior border. And this posterior border crosses the scleral spur, which is the anteriormost termination of the sclera as well. Now, if you go from outside to inside, outermost to innermost layers, there's your conjunctiva, and then there's your Tennant's capsule, which actually engulfs the globe completely, from originating from the optic nerve. And there's your limbal stroma underneath. And then you have your aqueous outflow structures just on the innermost side. So the transition is from corneal epithelium to conjunctival epithelium. The Bowman's layer of the cornea actually ends. So Bowman's bows out. Corneal stroma continues to become limbal stroma and then scleral stroma. The Decimet's membrane also ends. Decimet's is done. And then your endothelium of the cornea continues to become the endothelial lining of the trabecular meshwork in the anterior chamber angle. And the structures that begin at the limbal area, limbus, are conjunctival stroma, episclera, and Tennant's capsule. So these are the structures that that begin at the limbal area. Where's the blood supply to the conjunctiva? Well, it is from both the peripheral and arcades and anterociliary arteries, the palpebral portion and the posterior bulbar portion is mostly from the peripheral arcades. Again, these peripheral arcades are formed by the lateral palpebral artery. This is a branch of lacrimal artery on the lateral side. And then the medial palpebral artery, this is a branch of the ophthalmic artery itself. And they anastomosize to form these arcades around the eyelid, which also supplies the conjunctiva. The anterior bulbar supply is from the anterior ciliary arteries, And these are the branches of muscular arteries of the ophthalmic artery itself. Now, when you look at the venous supply, the venous drainage is from the interciliary vein. It goes to the deep scleral venous plexus, and then to the intrascleral venous plexus, then to the episcleral veins, and then the ophthalmic veins, superior and inferior ophthalmic veins. As you can see in these structures here, scleral venous plexus here, and then this is the episcleral venous plexus, and then your episcleral veins here that drain the blood out of the eye conjunctiva. Now the innervation, again, remember V1 branches, nasociliary, frontal, and lacrimal. The superior palpebral portion of the conjunctiva is from the frontal and lacrimal, and the inferior palpebral is from the V1 branches to lacrimal, and then the V2 branches to the infraorbital. Your drainage, the lateral side drains into the parotid, again, the medial side into the submandibular. Now let's look at the crystalline lens of the eye. The total refractive power is around 20 diopters. As you can see, it is much less than the cornea. And the shape of the lens is biconvex. It is aspheric because it is flatter towards the periphery. The refractive index of the lens actually varies from the center to the from the outermost part to the innermost part, from cortex to the nucleus. And the anterior radius of curvature is around 10 millimeters. Posterior is shorter, around 6 millimeters. And the lens actually has the highest protein concentration in the body, around 60% of the proteins in the lens. So here is another poll question for you. Which lens surface contains epithelial cells? You can respond to this poll by clicking on the link in the chat box again. This is anonymous poll, so please respond to this poll if you can, and then we'll discuss the answer. Let me put the link again if that is not working. I hope it is, but okay. Okay, the correct answer is the anterior surface of the lens contains epithelial cells. Let's look at the capsule first, which is the outermost part of the lens. It is hypertrophic, and it is the thickest basement membrane in the entire body. The capsule is produced by the anterior epithelial cells, and the capsule contains mainly type 4 collagen and gags. It is highly elastic due to the arrangement of collagen. The capsule is now thickest in around 3 millimeter area, just close to the anterior pole, and also just behind the equator, 1 millimeter area. It is thinnest in the posterior pole. As we said, the anterior surface of the lens contains epithelium. It is a monolayer of cells, and these cells are the primary source of lens metabolism. In this layer, the cells, the apex of the cells face the interior part, and the base face the capsule. And these cells can be organized into 3 different zones. Central zone, you have your intermediate or germinative zone, and then your transitional or equatorial zone. The germinative or intermediate zone is the source of all new fibers in the lens, and the transitional zone produces the crystalline proteins in the lens. Some points to remember for the crystalline lens is that there is no anatomical landmark between the nucleus and the cortex. Normally, the cortex is regarded as the outer 1/3 of the lens, and nucleus as the inner 2/3 of the lens. the primary posterior corneal opacity sometimes occurs in people who have undergone cataract surgeries and have the IOL implantation. And this is because the residual epithelial cells in the equatorial region often tend to proliferate under the posterior capsule, which is intact. And normally the arrangement of the fibers is such that the old fibers are at the center of the lens and the new fibers are just below the capsule. Let's talk about the zonules next. These hold the lens and these are the connection between the lens and the ciliary muscle. These are produced by the non-pigmented ciliary epithelium of pars plicat and pars plana, and also by the tertiary vitreous, organized into three different zones: tension, secondary, and primary. Primary are the ones attached to the lens. Secondary zone is the zone where the zonules are attached to each other, and the tension zones are connected to the ciliary processes. You can see in this figure here, the ciliary the zonules actually do not directly contact the ciliary processes, but they go into the valleys in the processes, into the basement membrane and the epithelium, and these zonules help to attach the ciliary body to the lens equator. Now, what happens during accommodation is an important thing to remember. When the eye is looking at distance and the eye is relaxed, the unaccommodated lens is actually thinner, and the zonules are under tension, so they are taut. And the ciliary muscle is relaxed. The zonules are taut, and then the lens is a little bit thinner in unaccommodated state. But during accommodation, the ciliary muscles contract. And because of the contractions, they move a little bit forward, which relaxes the zonules. So the distance from the ciliary processes to the lens becomes less, and it loosens the zonules, relaxes the zonules, and the front surface of the lens can become more rounder, and it becomes more rounder. So the movement is more in the anterior pole. Anterior pole moves forward in far greater amount than the posterior pole of the lens. Next, let's look at the sclera. Some of the attributes of sclera. It covers most of the globe, 80% of the globe, 20% is from the cornea, of course, and the radius of curvature is around 12 millimeters for the sclera. When you look at the thickness of the sclera, it is thickest at the posterior pole, around 1 millimeters, and is thinnest behind the insertion of the rectus muscle, around 0.3 millimeters. In the equator, it is around 0.4 to 0.6 millimeters, and just close to the limbus, it is around 0.8 millimeters. Now, if you look at the layers of the sclera, there is your episclera, which is the outermost layer, and then stroma, lamina fusca, and the innermost one, endothelium, and then there is your choroid coming on the innermost side. Now let's look at these layers a little bit more in a little bit more details. The episclera is a loose connective tissue. It is highly vascular, contains a lot of vessels, capillary networks from the anterior ciliary arteries. Again, these are the branches of the muscular arteries, which themselves are branches of the ophthalmic artery. And your sclera proper is a dense connective tissue. It is relatively vascular, mostly contains the type 1 collagen. The innermost is the lamina fusca, which is composed of the elastin fibers and melanocytes. And if you'd like to remember these layers with a mnemonic, it is Tesla, Tennant's capsule, episclera, sclera proper, lamina fusca, and yeah, those are the 4 layers of the sclera. Now, the color of the sclera is mostly defined by the arrangement of the collagen fibers. If the sclera is dull white or lacks transparency, it is often due to irregular fibers or variable spacing between the fibers. There may be differences in water binding substances like gags as well in the sclera, which can also lead to these color differences or dull white appearance of the sclera. In some conditions, you can see blue sclera, which is this thinning of the sclera occurs, and you can see the underlying uveal tissue. And you can remember these conditions by the mnemonic memories. Oftentimes, these occur in type 1 collagen disorders. Sometimes you see the sclera yellow in conditions like jaundice, where there is deposition of the bilirubin in conjunctiva. So you see the color of the sclera as yellow. Some of these conditions are hepatitis, alcoholic liver disease, and sometimes it can also occur in adults due to natural deposits of lipids as well. Now, there are several channels in the sclera for the passage of different structures. You have your anterior scleral foramen. If you imagine a globe without the cornea, then it leaves a large foramen. So this is your anterior scleral foramen. You have your posterior scleral foramen, which is the hole for the optic nerve to pass through. And there is your lamina cribosa, which is a mesh-like structure at the posterior part of the globe, where the optic nerve enters into the eye, and it is the part that is most likely to be damaged in glaucoma. And if you look at this picture in the lower right, here are those brownish spots inside the optic disc. These are fenestrations or holes for the passage of the optic nerve axons. There are also several canals or hemispheria for passage of different structures. Anterior hemispheria, through which the anterior arteries and veins pass. There is your middle hemispheria, through which the vortex veins pass, and posterior hemispheria, through which the long and short posterior arteries pass. And oftentimes you can also see these loops in the sclera. These are called the Axenfeld loops. And this is because the long posterior ciliary nerve comes forward, enters into the sclera, and makes a loop and turns around to go back. So this is formed by the long posterior ciliary nerves. Now let's look at the anterior chamber, and here's another poll question for you to respond by clicking the link in the chat box. Choose the correct order for angular structures from front to back: ciliary body, scleral spur, trabecular meshwork, Swalb's line; ciliary body, trabecular meshwork, scleral spur or Swalb's line; ciliary body, Swalb's line, scleral spur or trabecular meshwork; and the D, last one, is Swalb's line, trabecular meshwork, scleral spur or ciliary body. So the correct order for angular structures from front to back. So let's look at the structures from front to back. But before that, let's talk a little bit about the dimensions of the anterior chamber. And the boundaries of anterior chamber. The anterior boundary is, of course, the corneal endothelium. Posterior boundaries is formed by the iris. The axial depth is around 3.6 millimeters, and diameter is around 11-12 millimeters. It holds around 0.25 millimeters of aqueous humor. Now, there's also your posterior chamber just behind the iris, and the aqueous humor actually flows from the posterior to anterior chamber through the pupil. And this posterior chamber contains 0.06 milliliters of aqueous humor. Now, your angular structures from front to back are Swalb's line, trabecular meshwork, scleral spur, and your ciliary body band. So STSC. Now let's look at these structures again here. Solvay's line is the termination of the decimeter membrane, and this is often opaque in nature, and this is sometimes pigmented. It is called Sampolacis line. Sometimes it is anteriorly placed, in which case it is called posterior embryotoxin. And this is often made of collagen and elastin. Then you have your trabecular meshwork here, just behind the Solvay's line. The anterior part is non-functional, but the posterior part is functional and pigmented. And then you have your scleral spur, which is the anteriormost projection of the sclera. It is dense, white, and shiny. It is also where the longitudinal muscles of ciliary body insert. And then you have your ciliary body, and then the processes, ciliary processes. So what happens when ciliary body contracts is that it pulls the scleral spur down, and then that helps to open the trabecular meshwork, increases the outflow. And you can use some drugs like pilocarpine to contract the ciliary body to increase the outflow. So let's look at the trabecular meshwork in a little bit more detail. It is triangular in shape. The apex is at the Solvay's line, and the base is at the scleral spur. And there are three types of meshwork in trabecular meshwork. The uveal meshwork connects the iris and the ciliary body to the Solvay's line in front. The corneoscleral meshwork connects the scleral spur to the Solvay's line, and the juxtacanalicular, which is the layer of endothelial cells, actually is the enormous portion of the trabecular meshwork. Now, there are two pathways for the drainage of aqueous humor. One is the most significant one. 80% of the drainage occurs through corneoscleral path, trabecular meshwork, Slem's canal, collector channels, and then the episcleral veins. So posterior chamber to anterior chamber, and then trabecular meshwork, and out from the eye. The other is the uveoscleral path, in which the aqueous humor, when it reaches the anterior chamber, it drains through ciliary body and then suprachoroidal space, and then to the venous circulation. What happens after Slem's canal? Well, it drains into this episcleral venous plexus. After going through several different plexus, aqueous vein, your episcleral plexus, your mid-scleral plexus, and deep scleral plexus, finally into the episcleral venous plexus. And it drains into your superior inferior ophthalmic vein, and then to your cavernous sinus. And then from then on, it goes on to the superior vena cava. So condition called pupillary block is associated with abnormal convexity of the iris, in which the dilation of the pupil it causes the iris to be more flaccid. So there's your aqueous humor accumulating in the posterior chamber, which pushes the iris forward, causing the iris bombay. And this causes the peripheral iris to block the angle structure, causing an increase in IOP. And some of the risk factors for this condition are short axial length, shallow anterior chamber depths, narrow angles, and thick lens. There is the condition of abnormal concavity of the iris, and it is called pigment dispersion. There's also a condition called abnormal last roll or plateau iris, which occurs because the peripheral iris comes in contact with the trabecular meshwork. And the reason it happens is that the ciliary processes are pushed forward, which then pushes the peripheral iris to come in contact with the trabecular meshwork rather than the ciliary body. And oftentimes, even peripheral iridotomy does not help in this condition. Now let's look at the layers of the iris from from the anterior to the posterior side. On the anterior side, you have your anterior border, which often gives rise to your iris color. And then you have your stroma. Next, you have your anterior epithelial, where the dilator muscle is. And then you also have your myoepithelial cells in this layer. And the innermost one is the posterior epithelium, which is heavily pigmented. And oftentimes you can also see this pigmentation through the pupil, and that is called pupillary ruff at the margin of the pupil. So layers again: anterior border stroma, anterior epithelial layer, and posterior pigmented epithelial layer. And when you look at this cross section, you can divide iris into three different zones: the pupillary zone, mid zone, and the root of the iris in connection with the ciliary body. The iris is thickest at the collaret, which divides the iris into pupillary and ciliary portions. And it is thinnest at the pupillary margin, as you can see in the cross section. Here's the pupillary ruff that we talked about in the earlier slide. And this is basically the pigmented epithelium shining through the pupil area. Now, one thing to remember is the continuation of the layers of iris epithelium to the posterior ocular tissues. So the anterior epithelial layer is continuous with the posterior ciliary epithelium and retinal pigment epithelium. And the posterior epithelial layer of iris is continuous with the non-pigmented ciliary epithelium and the sensory retina in the back of the eye. Now, when you look at the cross section of the eye, here is your dilator muscle, just closer to the root than the sphincter muscle, which is closer to the margin. Your collaret, which separates the iris into pupillary and ciliary portions. And then your posterior pigment epithelium just underneath here. Now, sometimes the connections in the epithelial layers can break down, mostly due to the loss of desmosomes or microvilli, and this can give rise to these cysts, which are the collection of fluid in the iris, and these are called the iris pigment epithelial cysts. A couple of more landmarks to remember: crypts of Fuchs. These are series of openings located on either side of the collaret, and this allows the stroma to, and also to some extent, the deeper iris tissues to connect with the aqueous humor. And we talked about the collaret, which is the thickest part of the iris, and it separates the iris into two different zones. It separates the pupil section of the iris from the rest of the iris. The iris color is due to the amount of melanin, and melanin is within the melanocyte. This altogether is called melanosome. So individuals can have same number of melanocytes, but then they may have different amount of melanin in the melanocytes, which gives rise to the color of the iris. So melanosome is the site of storage and synthesis of melanin. Now let's look at the innervation of the iris muscle, sphincter and dilator muscle. The parasympathetic fibers actually originate from the Edingle-Westphal nucleus here, and then through the ciliary oculomotor nerve, they reach up to the ciliary ganglion, and then up to the short ciliary nerve to ciliary muscle. Oops. the sympathetic pathway, it actually originates in the hypothalamus and comes down, and then it reaches the superior cervical ganglion. And then so the postganglionic fibers then travel along the long ciliary nerve to the dilator pupillae muscle. Let's look at this in a little bit more detail here. So the pathway for the sympathetic or the dilation pathway, pupil dilation pathway, is hypothalamus, and then down to the spinal cord, and then the superior cervical ganglion. Then it travels along the internal carotid artery, along with the V1 ophthalmic, and then your nasociliary nerve, long ciliary nerve, and then finally the dilator muscle. Your parasympathetic pathway, it travels along the ocular nerve, then comes to the ciliary ganglion, and then through your short ciliary nerve supplies the sphincter muscle. Again, here it is again, Edinger-Westphal nucleus, ocular nerve, ciliary ganglion, short ciliary nerve, and then the sphincter muscle in the iris. How about blood supply? Well, you can remember the blood supply to the iris in terms of two major arterial circles. The first one is called the major arterial circle of iris, MACI. It is in ciliary body near the root of the iris. It has holes in it. It is fenestrated, so it is also the source of aqueous humor in the iris. And then it moves forward a little bit more into the iris, where it forms the minor arterial circle of iris, or MICI, which is non-fenestrated. It is located in the stroma of the iris. And while it does not form aqueous humor, it does help to form a blood aqueous barrier in the iris. So the flow of the blood is from major arterial circle to minor arterial circle, and then to the iris margin. And these circles are often formed by the anastomosis of long posterior ciliary arteries, which are branches of ophthalmic arteries, and then the anterior ciliary arteries, which is a branch of which are branches of muscular arteries of ophthalmic arteries. So they come forward in the anterior part, they anastomosize, and then form these circles in the ciliary body and then the iris. What about the venous drainage? The venous drainage is through the iridal venules into the ciliary venules, and then into the vortex veins, and finally superior and inferior ophthalmic veins. Most of these posterior ocular tissues, the venous drainage is through vortex veins into the superior and inferior ophthalmic veins. Now let's look at the ciliary body. And ciliary body, if you see here, this is the anteriormost part, almost like an extension of the choroid. It is vascular layer. It has similarities with the choroid because it is vascular layer. It is internal to the sclera, anterior to the choroid, and then posterior to the iris. As you can see in the figure here, it has ciliary muscle, which is a smooth muscle. It is not striated because it does not have the bands of fibrous tissues. And it has two parts. The ciliary body has two parts, which is pars plicata and pars plana. The pars plana is the posterior part, pars plicata is the anterior part, which also has the ciliary processes. Remember again, we talked about the zonules. The zonules insert into the valleys within these processes located in the pars plicata part. And if you look at these figures, a couple of anatomical landmarks to remember is the valley of Coot. And this is the valley within the ciliary processes where the zonules are attached. And if you note that the retina is coming from the posterior part, it is coming to the front, so it has to terminate somewhere, and terminates near the pars plana part. The part of the retina that terminates into the and connects with the ciliary body, it is the dentate process, whereas the part of the ciliary body that connects to the retina, it is called the oral base. Now, when you look at the layers of the ciliary body itself, from outside to inside, you have your supraciliary layer, and this is very loose. It is attached to the sclera underneath, and oftentimes it is the site of ciliary body detachment because it can accumulate fluid within itself. And then your ciliary muscle layer is just next to the supraciliary layer. You have your ciliary muscle layer, which is the largest intrinsic muscle of the eye. It has several fibers, three different types, in fact, longitudinal, radial, and circular fibers. The most number of fibers are of longitudinal type. And then you have your stroma, which as we talked about in earlier slide, contains the major arterial circle of iris. And the last structure is the ciliary epithelium, which is attached to the stroma. It divides into pigmented and non-pigmented epithelium. So the non-pigmented, the non-pigmented is the layer where the zonules are attached, and this is often the site of the production of aqueous humors. What about the blood supply to the ciliary body? We talked about the arterial circle of iris, the major arterial circle of iris, formed by the anastomosis of long ciliary arteries and the anterior ciliary arteries. The venous drainage, like for the most posterior tissues, it is through the vortex vein into the superior and inferior ophthalmic vein. The innervation to the ciliary muscle is from the autonomic nervous system, the parasympathetic pathway. These fibers originate from the Edinger-Westphal nucleus, and then they travel along with the third cranial nerve, oculomotor nerve, through the ciliary ganglion, along with the subciliary nerves, and then they innervate the ciliary muscle, which when contracts, it gives rise to accommodated lens, or more rounder shape of the lens, and helps in near focus. There's also sympathetic innervation to ciliary body, basically arteries within the ciliary body, and it is similar to the pathway that we talked before, originating in hypothalamus, and then down the spinal cord, and then to the superior cervical ganglion, travels along the internal carotid artery, and then through the long ciliary nerves, it supplies the arteries within the ciliary body. What about the sensory innervation? The sensory innervation is from the V1 branch, which is the ophthalmic branch of the trigeminal nerve. Remember, there are three branches: ophthalmic, maxillary, and mandibular. And then the ophthalmic branch has another branch, nasociliary nerve. Remember, the ophthalmic branch has three branches: nasociliary, NFL, frontal and lacrimal. Nasociliary branch itself has four branches, and one of them is long ciliary nerve, which supplies the ciliary body. The branch of nasociliary nerve you can remember by the acronym LIES, L-I-E-S, long ciliary, infraorbital, ethmoidal, and short ciliary nerve. Let's look at the choroid. It is another pigmented layer at the back of the eye, thickest at the posterior pole right here, and it is thinnest at the front, anteriormost termination part of the choroid, where it connects with the ciliary body at ora serrata, where it is 0.1 millimeters. It contains these, the outermost layer is Brooks membrane, which is connected, which is attached to the retinal pigment epithelium. Underneath that is the layer of choriocapillaries, which are fenestrated, and then they help to pass the fluid. There is your layer of small vessel and large vessel, satellars and halars. And then the innermost part is the suprachoroid, and then comes the sclera. Some points to remember for the choroid is that sometimes there can be a large number of blood vessels and melanocytes, melanin granules in the stroma of the choroid. And this is a condition where you need to be looking out for potential choroidal melanoma due to the increased accumulation of melanocytes in the choroid. Now, the choriocapillaries contain pericytes. These are the cells which are present along the walls of the capillaries, and these cells are often damaged in diabetes mellitus. So that the damage to these capillaries prevents the perfusion to the outer retina, and it gives rise to a whole sort of different manifestations of complications in diabetic mellitus, including diabetic retinopathy in the eye. Whereas in AMD, for example, it is the accumulation of the waste products, basically, in the basement membrane of RP and Brooks that causes the formation of drusens. And these drusens obstruct the nutrients to pass from the choroidal side to the RPE side. So the RPE is not getting the nutrients, and it is not able to metabolize these waste products. It cannot get rid of these waste products. These build up in the in between the basement membrane and Brooks, and so that causes the reduction of vision in macular degeneration. What about the blood supply to the choroid? It is mostly the anterior choroid is supplied by the posterior ciliary arteries, and the short posterior ciliary arteries here. These supply the posterior choroid. The long posterior ciliary arteries supply the anterior choroid. Now again, the drainage, like other posterior tissues, it is through the vortex vein into the superior and inferior ophthalmic vein, and then finally drains into the cavernous sinus. So the vortex vein to inferior and superior ophthalmic vein to the cavernous sinus. What about the innervation to the choroid? Well, your sympathetic fibers again travel along the internal carotid artery and through the V1, which is the ophthalmic nerve, and the branch of it is nasociliary nerve. It travels along the nasociliary nerve here through the long and posterior ciliary nerves. These are branches of mesociliary nerve. It innervates the choroid. And this sympathetic innervation causes vasoconstriction in the arteries of the choroid. Now, the parasympathetic innervation arises from the cranial nerve 7 through the pterygopalatine ganglion, through the petrosal nerve, and then into the choroid, which causes the vasodilation of the arteries in the choroid. And the sensory innervation is from V1, which is the ophthalmic nerve. A few notes on vitreous. It lies between lens and retina, and it contains around 80% of the globe. So it is the single largest structure in the eye. Volume is around 4 milliliters. It is mostly composed of 90% of water, and collagen type 2, can also contain 5, 11, and 9, and to some extent hyaluronic acid and glycosaminoglycans in the vitreous. You can divide into cortex and vitreous base. The cortex is a vitreous membrane. It is a layer of collagen that separates the vitreous from rest of the eye, and it contains hyalurocytes, which produces the hyaluronic acid in the vitreous. The vitreous base, on the other hand, it contains fibroblast. It is where the vitreous membrane, neural retina, and then the pigment epithelium are all connected together. And so these fibroblasts produce collagen fibrils for the vitreous. There are several anatomical landmarks to remember. Is your Cloquet's canal or hyaloid canal. It is the former site of hyaloid artery that nourishes the vascular lens during the development period. And this hyaloid artery regresses to become the central retinal artery later on. You have your area here, just at the posterior side of the hyaloid artery, hyaloid canal. And then your you have your Wicker's ligament here, which connects the anterior vitreous to the posterior surface of the lens. Your Berger's space here just behind the lens and the anterior surface of the vitreous. And you have your patellar fossa, which is just about here in this side. And then the actually this is the canal of Petit. This is bounded by the anterior hyaloid in purple here, anterior hyaloid, posterior lens zonules, and then the posterior ciliary body. This is the canal of Petit. And then there are several other conditions to remember. One is the epicapsular star, which is the remnant of the posterior hyaloid and anterior lens. There's Mittendorf dot, which is the remnant of the posterior hyaloid and the posterior surface of the lens, capsule of the lens. And then you have your Bergmester's papillae, which is the remnant of the posterior hyaloid and optic discs. Now, the vitreous can undergo different structural changes with age, and two of the important the changes are synchisis and syneresis. The vitreous can liquefy, and it can stretch, and it can break or even collapse, which is called the syneresis. Sometimes you can see the tobacco dust sign or Schaeffer sign, which is the collection of brown pigment cells in the vitreous. And this occurs after the vitreous detaches from the posterior attachment to the retina. Now, the strongest attachment side is at the base, vitreous base, and then to the optic nerve head, and then to the macula, and then to the blood vessels. And you can remember this by the acronym BOM, actually: base, optic nerve head, macula, and blood vessels. So let's look at the retina a little bit more. We're just about the 1.5 hour mark, just over it. So probably I'll take the next 10 minutes or so to finish up the retina, and then the visual field and the circle of Willis. So the layers of the retina, you can remember there are 10 layers in the retina, but an important point is that the light traverses all these inner layers to reach the photoreceptors. So going through all the neural retina to reach these outer retina part into the photoreceptors while the signal transduction begins. Now, when you look at the RP, it is a single layer of cuboidal cells the apical side is connected with the photoreceptors. It has microvilli which extends into the photoreceptors, and these microvilli help to phagocytose the discs from the photoreceptors. Now the RP layer actually directly attaches to the photoreceptors. There is no gap junction. And some of the functions of the RP is to remove the discs of the photoreceptors, to supply the food to the retina in terms of glucose, to act as a blood retinal barrier because of the tight junctions between the RP cells, and also to some extent to absorb light in the retina. And sometimes there can be deposits of different blood cells, damaged blood cells in the RP layer. And when that happens, you can almost tell that the RP is sick. And these damaged blood cells are accumulated in the form of a lipofuscin. So these are brownish pigments in the RPE. Photoreceptors contain outer segments and inner segments. The outer segment contains the discs. Inner segment contains the ellipsoid, myoid, and the cilium layer. Myoid layer makes protein, and the ellipsoid actually has mitochondria, so it is the source of energy to the photoreceptors. Cilium connects the outer to the inner segment. Now, when you look at the photopigments and how they evolve over time, these discs are formed in the inner segment, and then they are assembled in the base and at the base of the outer segment, and then they move forward and they are finally set at the tip of the outer segment. Remember that this lies just opposed to the retinal pigment epithelium in connection with the microvilli. So those microvilli help to phagocytose these threaded discs at the outer segment layer connection. And the two types of photoreceptors are different in terms of morphology. The rods are the outer segment is rod-shaped, tall and thinner. The photoreceptors are tall and thinner. The discs normally break away, and they are free floating. And these are said during the daytime, and the ending is called spiral. It is spherical shaped, and as you know, rods help in night vision. Whereas the cones have cone-shaped outer segment, shorter and stouter, and the discs stay attached to the outer segment. The discs are set at night, and the synaptic ending is called the pedicle. And as you know, the cones help in day vision. So the density of rods is greatest around 5 millimeters around the fovea, which is what is called the rod ring, whereas the cones has the highest density in the fovea. Now there are three different types of cone pigments: cyanobole, cyanolave, chlorolave, and erythrolave. These correspond to the red, green, and blue cone types, or long wavelength cone, middle wavelength cones, and short wavelength cones. And a few other things to remember regarding the synapses in the retina is that the outer plexiform layer is the place where photoreceptors connect with horizontal and bipolar cells. This is the first synapse in visual pathway. And this also receives both choroidal and retinal circulation. The inner nuclear layer contains the cell bodies of horizontal, bipolar, amacrine, and Muller cells. And this is the inner plexiform layer is another synapse layer containing the synapse of bipolar to ganglion, amacrine to bipolar, and amacrine to ganglion cells. And the nerve fiber layer is formed of the axons of ganglion cells. And you might have heard about the IS anti-agent rule in glaucoma, and this is because more axons are entering the optic nerve in the inferior side. So the inferior neuroretinal rim is the thickest, followed by superior, nasal, and temporal. And you have your papillomacular bundle coming from macula to the optic discs. This is the axons from macula to the temporal part of the temporal margin of the discs. In the nerve fiber layers, you can often see different types of exudates and hemorrhages. One of the types is cottonwool spots. These are the exudates in the nerve fiber layer. There are different types of hemorrhages. Some are splinter-shaped, some are flame-shaped, and these also occur in nerve fiber layer. And all of these are associated with the superficial retinal capillary layer. Now, if you look at the layers in the fovea, of course, the fovea is the thinnest part of the retina. So you have some of the layers are lost in the fovea. Most of the inner layers are lost. So you have your inner limiting membrane, and then Henle's membrane, which you can consider synonymous to the outer plexiform layer. And then you have your outer nuclear, external limiting membrane, photoreceptors, and RPE. So your inner plexiform, inner nuclear layer, and ganglion cell layer, these are lost at the fovea. And you can remember by the mnemonic, I hope, RPE. Where's the blood supply to the retina coming from? Well, the outer retina is mostly supplied by the choriocapillaries of the choroid, outer 1/3 of the retina, which includes the photoreceptors, retinal pigment epithelium. And inner 2/3 of the retina is supplied by the central retinal artery. In the inner side, there is two capillary networks, superficial in the nerve fiber layer and the deep capillary network in the inner nuclear layer. And remember that there's a blood-brain barrier, blood-retinal barrier formed by the presence of tight junctions in the retinal pigment epithelial cells. So when you look at the outer retina blood supply, this is often coming from the choroidal capillaries. Now the supply to the choroid itself comes from the long posterior ciliary arteries and short posterior ciliary arteries. So the short posterior ciliary artery supplies the posterior choroid, and the long posterior ciliary arteries supply the anterior choroid. Now, venous drainage is either through the central retinal vein to the superior and inferior ophthalmic vein, or through the vortex veins. Mostly from the outer retina, it is through the vortex vein. The inner retina, the drainage is through the central retinal vein. There can be the cilioretinal artery in some individuals, which is a branch of short posterior ciliary arteries. It is found in around 50 to 20% of the population. And in conditions such as central retinal artery occlusion, which is the occlusion of central retinal artery, it can provide perfusion to the retina, and also there is also perfusion to the fovea from the choriocapillaries of the choroid. So it gives rise to a typical pattern in the fovea. Then there are your veins that are present since birth, but they are only used when there is a blockade of venous drainage. These veins are called the collaterals, and these are normally associated with the central retinal vein occlusion. Now let's review the visual fields. We'll finish up with the visual fields and then the circle of Willis, because these were the two topics that were requested in our previous review session. Now, when you look at the retina itself, the portion of the retina nasal to the optic disc is the nasal retina. On the temporal side, temporal retina, you have your macula there, and then the superior and inferior retina. Now, these parts of the retina correspond to opposite parts of the visual fields. These project to the opposite parts of the visual fields. For example, the superior temporal part projects the inferior nasal part of the inferior nasal visual field, and then the superior nasal retinal field projects to the inferior temporal visual field. Now, remember that there is a decussation of the fibers in the optic chiasm, at the optic chiasm. So the fibers from the nasal side decussate, but the temporal side, they stay the same. So when you look at this, after the crossing, the temporal side remains the same, but the nasal half is derived from the contralateral eye. So the fibers from the nasal side of the contralateral eye. And oftentimes, when you look at the fibers from the inferior nasal region, now these fibers, inferior nasal fibers, when they are crossing, they sometimes enter into the contralateral optic nerve at the anteriormost part of the optic chiasm, and this is called the Willebrand's knee, anterior knee of Willebrand. So if there is a lesion here in this area, and so this is the lesion for the inferior nasal fibers for the left eye, and in this part, the nasal and temporal fibers from the right eye are all damaged. So this gives rise to an absolute scotoma on the right eye. But because the inferior nasal retina is damaged in the left eye, you get the scotoma in the superior temporal region of the visual field. So this is called the quadrantopsia or junctional scotoma on the left visual field. But for the right visual field, you have what is called the absolute scotoma. Now, it is important to remember the crossing of the fibers at the optic chiasm. Basically, your superior fibers, superior temporal fibers, they do not cross; they stay superior. Your inferior temporal fibers, they do not cross; they stay inferior. What the fibers that are crossing are the nasal fibers. So your inferior nasal fibers, this is the retina, this is after the crossing. Inferior nasal fibers are crossing in the anterior part of the optic chiasm. They try to enter the contralateral optic nerve, they make a loop, and then they go forward. This is called the anterior knee. And then the superior nasal fibers cross in the posterior part of the optic chiasm called the posterior knee. What about the macular fibers? When it comes to the macular fibers, again, the temporal fibers do not cross. It's the superior, inferior, and nasal fibers that cross at the posteriormost part of the chiasm. So the fibers that cross are the superior, inferior nasal macular fibers, but not the temporal macular fibers. Now, to finish up this review session, let's talk about the circle of Willis, which provides circulation in the brain, and it is formed of anterior and posterior circulatory systems. The anterior one is from the internal carotid artery. The posterior is from the vertebro-basilar artery system. And most of the circulation is from the internal carotid artery system. But let's look at the circle of Willis from the posterior part, coming up towards the anterior part. Now, if you remember your branches coming out of the aortic arc, you have your left subclavian and left common carotid, and on the right side you have your right brachiocephalic artery, which gives rise to right common carotid and right subclavian. And it is subclavian that gives rise to these vertebral arteries that are coming up. So they continue to move up, and then they give several different branches on the way. One of those branches is the anterior spinal artery, and these arteries from the two sides join, and they come down to the spinal cord. And when the vertebral artery, as it travels upwards, it is called the basilar artery. There are several branches of this basilar artery. The posterior most branch is the anterior inferior cerebral artery, which of course supplies the cerebellum. And then you have your labyrinthine artery, pontine arteries, and as it moves forward, it gives the superior cerebellar artery, and then your posterior cerebral artery. Now, this artery is connected to the internal carotid artery by the posterior communicating artery. So here is the connection between the internal carotid artery system and the vertebro-basilar system. You have your internal carotid artery here, which gives rise to the middle cerebral artery. And then on the anteriormost part, these arteries on the two sides, they connect with the anterior communicating artery. The anterior cerebral artery connects with the anterior communicating artery. And one of the branches of the internal carotid artery is the ophthalmic artery. So this is the circle of Willis, which is the anastomosis of the internal carotid artery system and the vertebro-basilar artery system, which helps to supply different areas of the brain. So that's it for this review session. I hope the information of this review session was useful to you, and I wish you the very best for your examinations. If you have any questions or if you need any clarifications, you can always contact me by email, or you can make an appointment to see me in my office in Henry Peters Building 526. Thank you for joining, and have a good rest of your evening.